Thank you, Officer. Next presenter is Dr. Mohsin Quadri. He'll be talking about primary bladder pain this is other types of chronic primary pelvic pain syndromes in men. So beyond bladder centric, let's move ahead.
Hello, good evening, everyone. Good evening, dear chairpersons, faculty and delegates. Myself, Dr. Mohsin, I'm Assistant Professor in Department of Urology, Guntur Medical College. At the outset, I thank Dr. Sanjay Pandey sir and Rajesh Taneja sir for GIBS for giving me this opportunity. And here the topic given to me is on other types of primary CPPS. So here, these three syndromes are overlapping syndromes where I'm going to deal about primary prostatic pain syndrome, scrotal pain syndrome, as well as urethral pain syndrome. So one by one, I discuss in brief. It's also called as CPPS 3B, prostatidynia primary and primary prostatic pain syndrome. It's defined as like persistent or recurrent pain centered in the prostate region for at least 3 months of previous 6 months in absence of infection or any other pathology. The symptoms, the classic symptoms are like low backache, perineal pain, penile tip pain, the post-ejaculation or on chronic sitting, long-standing sitting, the bladder region pain, and urinary symptoms, fatigue, arthralgias, and sexual symptoms. So they are multifactorial, as Tanvir madam said, a lot of CNS involvement, like the CNS sensitization as peripheral nerve sensitization in the form of C fibers. And there might be a pelvic floor muscle dysfunction and a lot of immune and endocrine factors involved. And finally, stress and anxiety related as well. Coming to this is a diagnosis of exclusion, as I said previously. And history is the main, as we all, as a clinicians, we need to have a proper history taking. In that, there are a lot of symptom scores, out of which U point, which is like mentioning of the symptoms and psychological symptoms, obstructive and infection, neurogenic, all we need to rule out, and we need to put together in the scores, like NIH CPSS score is there. Based on this score, 0-3 is mild, 0-3 is mild, 4-6 is moderate, and 7-10 is severe. We will categorize as per the symptoms and do a proper physical examination, where a proper distal rectal examination and eliciting any tender point, and those tender points which elicit those pelvic pain. And we need to rule out infection with the help of like urine, semen, or expressed prostatic secretions. We need to rule out infection, and uroflowmetry we do to rule out any flow problems, obstructive problems, and to do a transrectal ultrasound to rule out any prostatic lesion. Coming to treatment modality, like educating to the patient regarding the pain, pelvic physiotherapy, the alpha blockers, what we use routine are alfuzosin, silodosin, and a short course of antibiotics, some NSAIDs to help from pain. There are like pollen extracts and quercetin in the form of phytotherapy, and psychological support to the patient. The neuromodulation and stress management as well helps. And these are new aspects like extracorporeal shockwave therapy and intraprostatic botulinum toxin are in research. Now coming to the second syndrome, which is all of the primary scrotal pain syndrome, is also called chronic scrotal content pain, chronic arcalgia, primary scrotal pain syndrome. By definition, it is episodic or persistent scrotal pain for more than 3 to 6 months, which is localized to scrotum. That is either from contents of testis, epididymis, or spermatic cord, with no evidence of infection or any other pathology. As we see this syndrome, mostly in the post-vasectomy, post-hernia repair, or in the post-localized trauma to the scrotum. And most of these pain might attribute to neuropathic as well as referred pain. So here we need to rule out the infection in terms of doing a semen culture, and by doing a proper scrotal ultrasound to rule out all the tumors, varicocele, and with a proper physical examination. As usual, we did in the previous case, the good distal rectal examination and uroflowmetry to rule out other causes as well. And here there are multidisciplinary treatment modalities are there, and the pelvic physiotherapy, myofascial trigger point, nerve blocks, and psychological therapy. Adding to it, the surgical intervention, in the case of its post-vasectomy, like it's a vasovasostomy, sometimes orchiectomy and epididymiectomy helps. And in sometimes neurogenic causes like microsurgical spermatic cord denervation will be helpful. Coming to my third syndrome of primary urethral pain syndrome, here it is defined as chronic urethral pain or dysuria accompanied by urgency, frequency, or nocturia without any urinary infection or any other pathology. So there are various theories underlying. Some says like subclinical infection of periurethral glands, and sometimes they say like it is an early part of a bladder dysfunction or interstitial cystitis. And as usual, like previous things, like the sensitization of the peripheral nerves, and in some studies it shows as a estrogen deficiency. Diagnosis we do by the means of like eliciting a proper clinical examination, eliciting the urethral tenderness, and doing a urethroscopy, ruling out the inflammation of the urethral mucosa, and doing cultures, taking cultures, excluding the infection, and as usual, the routine bladder, prostate, and pelvic floor muscle examination, as I said in my previous slides. Coming to the traditional treatments like urethral dilatation and steroid combination antibiotics and ointments, what we use, we can give alpha blockers for symptomatic treatment, antibiotics, and acupuncture and laser therapies, some psychological treatments, as well as neuromodulation. These are all various modalities. And to deal all these things in a common management, like first we need to rule out infection, obstruction, malignancy in all these three things, as it is a diagnosis of exclusion. And there are like pelvic floor muscle dysfunction and.
Sorry to interrupt. I think the time is up, Dr. Quadri.
It's a central sensitization. And there are like multimodal treatment modalities, like using alpha blockers, NSAIDs, and using neuropathic pain agents like gabapentin, which we use in our regular clinical practice. Pelvic physiotherapy and psychological care, stress management.
Dr. Quadri, sorry to interrupt.
I'll sum up, madam.
Yeah,
I'm adding the slides. So, and doing extracorporeal shockwave therapy and botulinum toxin are recent, as I said, emerging therapies. To sum up all these three syndromes in my slides, like the perineal pain is commonly shared in the prostate pain syndrome as well as urethral pain syndrome. And both are like more than 3 months in duration, prostate pain syndrome and scrotal pain syndrome. As I discussed, all those investigating modalities and those pain treatments has been discussed. And my take-home message is all these syndromes are confusing and both are all intertwined. And we need to differentiate with a good clinical acumen and proper evaluation. There should be a good evaluation with a multi-disciplinary team involving a urologist, a pelvic floor physiotherapist, pain specialist, and a psychologist. Early diagnosis and good care, like multimodal care with a holistic approach, you can improve the outcomes and quality of care of the patient. And I thank one and all for your patient listening. Thank you.
Thank you. May I?
Next one is